Hi everyone, and welcome back to another Corsmed MRI video. Today's topic and protocol is for brain tumors. So I'm going to swap over to the simulator, and we're going to take the entire protocol step by step. Let's go! Here is the Corsmed MRI simulator, which is where I'll walk you through this protocol. Now, brain tumor MRI is a comprehensive scan designed to characterize lesions, assess their extent, plan treatment, and monitor response. The full protocol typically takes around 30 to 45 minutes and includes both pre-contrast and post-contrast sequences. Because this is such an extensive protocol, we've split this tutorial into two parts. In this part 1, we'll cover the theory of brain tumor imaging and walk through all the pre-contrast sequence planning. Then in part 2, we'll handle contrast injection, post-contrast sequences, and complete image review. So, let's begin with the key anatomies and medical conditions we must capture in a brain tumor protocol. First, we need to establish baseline anatomy and detect any pre-existing brightness from blood or melanin. These are clearly seen on pre-contrast 3D MP-RAGE sequences in T1 weighting. This sequence shows what's bright before contrast, which prevents false enhancement calls later. Next, we look for low-grade gliomas and infiltrative tumor margins. These conditions are best visualized with FLAIR fat-saturated sequences, which suppress cerebrospinal fluid to reveal non-enhancing tumor extent and infiltration. We also assess vasogenic edema and cystic tumor components. These show up clearly on T2 sequences, which highlight water-rich tissues and show edema around tumors and fluid-filled areas. Another important condition we look for is brain abscesses and acute infarcts that can mimic tumors. These are best detected with diffusion-weighted imaging with ADC output on. Restricted diffusion with high DWI signal and low ADC indicates pus or ischemia. Additionally, we check for hemorrhagic metastases and cavernous malformations. These are clearly seen on T2 star gradient echo or susceptibility-weighted imaging. The susceptibility effect shows blood products as dark blooming artifacts. The most aggressive tumors, like glioblastoma and brain metastases, are detected on MP-RAGE post-contrast sequences. This sequence reveals blood-brain barrier breakdown as enhancement, making it the primary sequence for aggressive tumors. Finally, we look for meningiomas with dural tail and dural metastases. These are best visualized with T1 fat-saturated sequences with contrast, where fat suppression makes dural enhancement stand out clearly at the skull base. Each sequence provides specific information that together gives us a complete picture of the tumor's characteristics, extent, and composition. Now, to produce clear diagnostic images for all of these conditions, we need to understand how to balance the three core MRI trade-offs. In every scan, we have three key metrics to optimize: scan time, resolution, and signal-to-noise ratio. If we improve one of these, it will negatively impact the other two. For brain tumor imaging, resolution and SNR are nearly equal priorities, with resolution slightly ahead, and scan time ranks third. However, if the patient can't hold still, then time trumps everything. Let me explain why this order makes sense. Resolution is our primary goal because missing a 2 mm metastasis could change treatment decisions entirely. We also need to differentiate between tumor types and detect infiltrative margins, which requires clear visualization of fine details. SNR is our second priority, but it's not a goal to maximize in itself. Rather, SNR must be good enough to make our images diagnostic. The key is having adequate SNR relative to our resolution targets. At 3 Tesla, we typically have enough SNR headroom to achieve good resolution within practical scan times. At 1.5 Tesla, however, we need to be more careful not to drop SNR too much when pushing for higher resolution. Scan time comes third, though it's still critical. Around 30 minutes is the practical limit for most patients. Beyond that, motion artifacts can destroy even excellent SNR and resolution. For uncooperative patients, it's better to sacrifice some resolution, or SNR, rather than risk motion blur that makes images completely unreadable. Now, let's get started with the protocol. In our scenario, the patient is already positioned. We've taken care of immobilizing them and making them as comfortable as possible, which is especially important for this protocol. Now we're going to close the scan room and acquire our first localizers. Once finished, we can drag and drop them into viewers and scroll to a central slice in each viewport. So first the axial, then the sagittal, and finally the coronal. Now let's quickly review the setup we're going to use. We'll use a model with a tumor pathology, which can be switched on in the patient settings. Next, we'll select a multi-channel coil because it maximizes signal-to-noise ratio and enables parallel imaging for faster acquisitions. We're going to use 3 Tesla for this protocol. 3 Tesla is usually preferred for tumor imaging as it provides higher SNR for thin slices, better contrast resolution for small lesions, and improves spectroscopy and perfusion quality. Most setups will still use 1.5 Tesla, as that's often the only option available, especially in patients who carry devices or have contraindications. Keep in mind that higher magnetic field strength at 3 Tesla will increase artifacts from metal. For gradient strength, we want to use 45 to 50 millitesla per meter. This allows us to acquire fast 3D sequences with isotropic resolution. It also enables high-quality diffusion-weighted imaging with multiple B values. In addition, this max gradient strength lets us do perfusion imaging with rapid temporal resolution, but we won't demonstrate perfusion today. For this tutorial, I'll also have a low amount of noise turned on in the simulation settings, because I want to demonstrate some optimization strategies. Now we have our localizers uploaded in the viewports, so let's scroll through to a central slice in the axial, sagittal, and coronal views. Check that the localizers are aligned and that the head is well positioned with no rotation of the nose. Most importantly, note if there are any previous surgical changes, like a craniotomy or a shunt, and check for correct positioning in the ISO center. Now let's talk about what we want to image. Our goal is complete brain coverage from the vertex down to the foramen magnum so that we capture the full extent of the tumor, including any infiltrative margins. Surrounding structures like ventricles, eloquent cortex, major vessels, skull base, and meninges must be visible to assess for dural tumor involvement. Our superior landmark will be the vertex, including the entire lesion if it extends superiorly. Inferiorly, we'll go to the foramen magnum, or base of the skull, including the upper cervical cord. Laterally, we need both hemispheres clearly depicted in the axial plane. We're particularly interested in tumor margins and their interface with normal brain. The relationship between the tumor and ventricles is important, and we need to check if the tumor infiltrates them. Mass effect and midline shift also need assessment, checking if the midline is pushed backward or downward from the mass. The optic chiasm and any pituitary involvement require evaluation. Finally, involvement of major vessels like the circle of Willis and venous sinuses must be assessed. Now, let's move on to selecting the sequences for this protocol. This setup I'll show next is a general guideline that works well in most cases. However, your organization may have additional sequences not explained here, so always communicate with your radiologist to discuss each case. For the core tumor protocol, though, we can find the sequences we need in the brain routine menu. First, we need a 3D MP range, or SPGR, in sagittal. Most often it's acquired with T1 weighting, and I'm going to add it to our position. This sequence is crucial for anatomical reference and to establish a pre-contrast baseline. It'll have isotropic resolution and enable multiplanar reconstruction on any plane. Next, we'll acquire a T2 Axial to evaluate the tumor's internal composition. This should be with as high a resolution as possible. Then our conventional FLAIR will be acquired, which is critical for detecting tumor infiltration beyond what we see with contrast. Then we'll acquire diffusion-weighted imaging with B values of 0 and 1000. The ADC map from this sequence will help us assess tumor cellularity and distinguish abscess from necrotic tumor. Next, a T2 star gradient echo will be acquired to detect any hemorrhage or calcification. At this stage is where we're going to inject contrast. After contrast, the 3D T1 sequence needs to be repeated. Then we'll add a T1 post-contrast in axial. As you know, contrast shortens the tissue relaxation times, which enables us to get very strong signal. Sometimes we even get hybrid imaging in T1/T2 because the fluids are hyperintense due to contrast, but the time to achieve that hyperintensity is much less because of the contrast effect on the tissues. Finally, we'll add 2 T1 post-contrast sequences in coronal and axial planes. So this is the entirety of the protocol. Let's get started with the 3D T1. This sequence will actually be planned as a sagittal, so let's quickly rename it. And then I'll go to the plane orientation here in the geometry tab and set this to sagittal. I'm going to drag it to the middle because I want each slice to be parallel to the mid-sagittal line. If you're struggling to see where you're looking, you can review in box mode so you only see the midline of the middle slice, which is perfectly aligned with the sagittal. We can see on the sides that we can probably spare a couple of slices, so I'm going to remove them. It's not a lot because it's still a 3D acquisition. We still want to cover side to side, but we'll do anterior-posterior face encoding because it enables us to keep the smallest field of view. Since we want isotropic voxels, we need to keep the same dimensions in the read and phase directions for both field of view and matrix. We can see the isotropic dimensions over here in our blue box. Ideally, we want to aim at 1 millimeter cubic voxels. Here it's 1.2, which is appropriate, but if you can go down to 1 millimeter cubic, that's perfect. Remember that we must also maintain a high SNR, so we don't want to drop our signal too much. If you think you can safely boost your matrix, you can do so. Let me try adjusting this to get exactly 1 millimeter cubic voxels. Because our voxels are now much smaller, you can see that we have cut off some of the sides of the brain here in our axial. So to solve this, I'm actually going to go back to our old geometry settings so that we again have the same 1.2 millimeter voxel size, but with full coverage of the brain. Of course, this is part of the trade-offs. Let's keep going and accept that 5 to 6 minutes acquisition time is acceptable. We also want to check that we have a nice weighting for this sequence. All looks good, so let's run this pulse. This sequence will serve as a baseline for comparison with post-contrast images. Now we'll move ahead to the T2 Axial Fast Spin Echo. This is a standard axial sequence that we also covered in the routine brain video, which you can find in the caption. But just to summarize, we want to plan parallel to the line connecting the genu and splenium of the corpus callosum. That's basically the midline of the central slice. We want to cover from the vertex to the foramen magnum. We also want a slice thickness of 3 to 4 millimeters, slightly thinner than for routine brain, which means we need to boost up the number of slices. For slice gap, you can use either 0 or 1 millimeter. In this case, I'll go with 1. We want very high in-plane resolution, typically 0.5 millimeters squared, but we'll use 0.7 for this simulation, as that is the lowest value allowed. So let's boost our matrix to 320 in both the read and phase. Of course, we're going to use right-left phase encoding. We want to keep the blur minimal, so we're going to use a moderate echo train length, which is 20. Perhaps we can go down to 16. This will take roughly 3 to 4 minutes in scan time. To avoid blurring, let's drop it a bit further to 12. Now let's save it, and we'll then start planning the axial FLAIR. Here, we want the exact same slice prescription as the axial T2, so I'll right-click on the T2 and choose Copy All Slices. We're also using a long TR and TE because this will be planned as a T2 weighted sequence. For 3 Tesla, we'll use a TI around 2,500 milliseconds to null the cerebrospinal fluid. This sequence is excellent for detecting tumor infiltration beyond enhancement, vasogenic edema, and cortical involvement. As always, we're around 3 to 4 minutes scan time. Our 3D T1 has just come out. It looks good, but we'll review it later. For now, we can launch the T2 fast spin echo that we just planned. Let's carry on with the diffusion-weighted imaging with ADC map on. We want to use the same positioning of the other axial sequences, so we'll choose custom and pick the center position. Then we'll pick the size of the field of view, but we're not picking the matrix because diffusion looks at tissue function, how water diffuses at a molecular level, rather than morphology, the structure of the tissue. So it doesn't need the same high resolution as FLAIR. We also don't want the same slice parameters, so we can uncheck all of those and then copy just these three. Or actually, even if we don't have the same resolution, we can still copy the slice thickness and gap so that images align when we review them side by side. We'll expand the number of slices, always a touch below the skull, but not too much to cut anything out. Then let's go to the special tab. Here, we want one acquisition at b-value 0 and another at b-value 1000. The simulator is set up to automatically generate the ADC map. You can also apply fat suppression, which is required in this case and will be spectral based. This sequence is highly critical for tumor cellularity assessment, abscess differentiation, and acute infarction in tumor bed. Now that the T2 is finished, we can run the FLAIR, which will take around 2 to 3 minutes. We can then save our DWI sequence. And finally, we have our T2 star gradient echo. Again, we're going to copy the slice planning from the previous axials so we can compare the images. If higher sensitivity is needed, we could instead use susceptibility-weighted imaging. The T2 star effect doesn't perform very well at 3 Tesla, but I'm going to show it as a demonstration. Again, we'll use exactly the same configuration. As you can see, there's a 1:10 ratio between TE and TR. It's a good balance that's always respected in gradient echo. This sequence detects hemorrhage in melanoma, metastasis, or high-grade glioma, as well as calcification, vascular malformations, and microbleeds. It's very important if there's suspicion of acute bleeding from the tumor. So with that, we are done with all our pre-contrast planning. We've covered the medical conditions we're looking for, the trade-offs we need to balance, and we've planned all 5 pre-contrast sequences. In part 2, we'll continue with contrast injection, post-contrast sequence planning, complete image review, and key diagnostic principles. Thanks for watching, and I will see you in our next video.